So for milk production, the movement of substances from the bloodstream over to milk happens in a variety of different ways, which we'll get into. Maternal diet can influence the composition of milk, only to a certain extent, but certainly some spices can get into breast milk more easily. The color can be impacted by diet. A little bit of the fat content can depend on what mom's maternal diet is for fat consumption. Some babies might be fussier with certain foods in maternal diet, but really it only impacts it to a point. So for example, I've seen one study looking at women who were especially malnourished. The study was done in sub-Saharan Africa, and they compared the breast milk composition of the milk of those women to women in the U.S. who were considered to have more of a balanced diet. And they found that the breast milk composition was essentially the same between the two. So when I'm thinking about nutrition for people who are breastfeeding, I'm more concerned about the nutritional status of the woman herself, because regardless of what you're eating, breasts are going to pull out the nutrition that baby's needing. So let's encourage good nutrition, because if a mom is just eating junk food, then every good bit of nutrition that she does have is going to go to her baby, and then what's left for her? I think this is also important to just recognize that regardless of a mom's nutritional status, she still has something great to offer her baby. Breastfeeding should certainly still be encouraged regardless of what her diet is. Tapping into resources like WIC in your community can also be a huge benefit here as well. Breast milk has good proteins, including casein, whey, and IgA, which is an antibody. So the IgA is able to function as an antibody in baby's gut until baby consumes it as a source of protein, which is just amazing. And then we also have sugar or lactose. And then of note, it is rare to have a baby that's lactose intolerant to its mother's breast milk, though certainly that could be a possibility. So now a little more on the milk ejection reflex or letdown. So it's needed for continued lactogenesis initially, and then it's also needed for proper volume intake in young babies. So what are signs we can see that let us know that letdown is happening? For mom, these are really signs that oxytocin is on board. So she may feel sleepy, thirsty, feel uterine cramps, hot flashes. She may say she feels tingling in her breasts, which some women do report as feeling painful. So you could keep that on your list of differentials, but most would just report it as feeling tingling or not noticing. For babies, when letdown happens, you can expect to see an increase in the number of swallows and gulps. So initially they're suckling, and it might sound like suck, 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 swallow, suck, 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 swallow, suck, suck, swallow. And then when letdown hits, it's suck, swallow, suck, swallow, suck, suck, swallow. So you can be listening as well as watching their jaw and their throat for sucking and swallowing. So there are some things we can do to help facilitate letdown. So gently massaging the breasts and nipples before latching can help. Moist heat to the breast or nipples 2 to 5 minutes before latching can also help. There are numerous inhibitors to letdown, so intense fear or anxiety, those increased catecholamines, extreme pain, fatigue, lack of support, poor latch, all of those can be an inhibitor for oxytocin being released for the letdown. You can see those are similar inhibitions for labor progression too, in needing that regular stream of natural oxytocin release. So for both labor as well as nursing, easing fears, creating a safe space, plenty of support, all of that goes into helping support her natural physiology to do what needs to happen. So milk will change throughout a feeding session. It'll start with foremilk, which is the first milk out of the breast, and it's more watery, and it's intended to quench baby's thirst. And then it's also high in protein, which is great. And then we don't want to quick pop her off that side and put her on the other side, because we know that what's coming behind the foremilk is hind milk. So hind milk is the last milk out of the breast, and it has a much higher fat content intended to satisfy babies. We want to encourage parents to keep their babies on long enough that they're getting that hind milk from at least one of the breasts. I see this more so being an issue with moms who have multiple children, where maybe they're having pretty busy schedule from day to day, and they're wanting to quick nurse this side, that side, and then out the door again, and they're not necessarily keeping their babies on long enough to get that hind milk, and so then they're saying, my baby's wanting to eat every hour, which could also be normal, but sometimes just giving baby long enough to stay on the breast and fully empty at least one side before moving to the other, or maybe they don't even need the second one, but to fully empty one breast and possibly fully empty the other one too, ensures that they help get that hind milk on the backside, and that's going to keep them satisfied for longer. And there's no correlation really with how much time is spent at the breast or let down to ensure that they're getting that high milk. It's really highly variable from one dyad to the next. So maybe one mom has 20 straws or ducts leading up to her nipple and another mom only has 6, so it's going to take longer. Or maybe one baby has a really vigorous suck and one baby likes to be a little lazier at the breast and kind of sip here and there. So we want to encourage moms to be patient and be willing to put in the time that's needed for their specific baby to get what they're needing. And in this image here on the left, you can see foremilk. So you can see that it's a lot waterier. And then on the right, you can see hind milk. So it's a lot fatter and richer. So now biologic specificity of human milk. Initially, it's colostrum for the first 0 to 5 days. I really don't see it beyond 3 days for it to start transitioning, but that's technically your time frame. It's thick, golden, and protein packed. It contains all nutrients needed for baby. Baby really doesn't need anything else. There are a number of cultural groups who tend to want to formula feed until milk comes in. So this would be a good teaching point as well as a listening point for navigating how to best support mom and baby. It contains a high concentration of immunoglobulins, which is great because we don't have a very strong immune system yet, and we're used to the placenta being able to filter out everything. So having that extra bit of immunity is great. Ratio-wise, colostrum has a lower percentage of both fat and lactose. And then it's worth noting that the junctions between lactocytes are wide, meaning that it's easier for things to get into breast milk. So if you're considering whether or not a medication would be a good choice for lactation, or if a mom's talking about maybe wanting to drink a little bit more, just to be aware that in those first few days with colostrum, up to those first couple weeks, those junctions are wider and more of whatever mom is consuming is getting into the breast milk than would be typical for lactation across the board. And then colostrum is also quite a bit more concentrated with less water, which is why it's not uncommon for babies to lose a little bit of weight in those first few days and that first week. We don't want to cross over that 10% threshold, but to have a little bit of a weight dip isn't uncommon with colostrum being more concentrated. So then that first week, day 5 plus or so, we start getting transitional milk, and that's when we talk about the milk coming in. So more lactose and more water are added to the colostrum. Milk is a higher volume, and we see weight start to climb back up again. And then those junctions between lactocytes start closing, so it's more selective for what gets into milk. And then in that first month or 2 to 6 weeks, we get mature milk. So then it's more of a thinner, creamy, white milk. And then junctions are very tight and highly regulated, so not very much is getting into milk at that point that's not intended for the baby. And mature milk over time can sometimes become a little bit less rich and potentially have a bluish hue too, and that's normal and fine. So you may see moms mention or ask questions about that too. Goat milk is considered to be the most similar to human milk. Cow's milk is quite a bit higher in protein as well as lower in sugar, so definitely there's a sense to human milk being most specific to the needs of newborns. It's got good high fat content for brain development and what have you. I see this picture and I think of Mary Breckenridge. She's essentially who founded nurse midwifery in the U.S. She's the one that started Frontier Nursing Service that's still a university today for midwives in Kentucky. And she was raised in Europe. And she wrote about how as a young child, she actually nursed from goats. So this picture reminds me of Mary. All right, moving along. I've got this picture here where you can see the progression of colostrum, both in terms of volume and kind of color and density as it progresses over to mature milk in that first month of life. You can see from day 5 to 6, that was a pretty big increase in terms of volume too. So looks like around day 5 to 6 was when this person's milk was coming in. And then, of course, we also have a lot of immunologic components to breast milk, too. that are really what set it apart, breast milk versus formula, in being able to add these immunologic protective components to milk that really help, especially once babies start crawling and putting everything into their mouths. This essentially serves as like a daily vaccine for helping keep them healthy, especially given that their own immune systems are still really immature. And as a bonus, some of these components are even specific to the environment that they're in. So whatever environment mom's in, her IgA antibodies are more specific to that direct environment, addressing the specific pathogens that the baby might experience in his or her daily life. So we've got antibodies, we've got hormones and proteins that help to close the gut, we've got lymphocytes and macrophages. Lactoferrin does bind to iron, which is less ideal for it being available to the newborn, but it does mean that it's not available to microbes, so that does have a protective effect for the baby. Oligosaccharides can inhibit microbes as well, and then we've also got probiotics, which can help to prevent diarrhea, which can be a huge issue for young children and is a leading cause of death even worldwide for having diarrhea. So probiotics are protective for newborns as well. And I guess I can clarify, it's the dehydrating effects of diarrhea as well as the potential pathogens that are leading to diarrhea that make it a leading cause of death worldwide. So now let's just briefly talk about breast versus bottle feeding. So just one bottle won't hurt, or will it? So let's just keep this in mind in the grand scheme of how we're managing a person overall in their breastfeeding journey. Are there downsides to using formula alongside breastfeeding? Really, just one bottle will affect baby's GI flora long term. So within 24 hours of having had formula introduced, an infant's GI flora will turn into an adult flora. And if they do have, say, one bottle and they want to go back to exclusively breastfeeding, it would take 2 to 4 weeks of exclusively breastfeeding or using express breast milk or donor milk in order to return back to that infant floral state. So this is one reason why, if you're finding that supplementation is necessary, because it absolutely is sometimes, the first place to start would be, could we use mom's own express breast milk? And if not, is there donor milk available? So then the benefits to breast milk would be that decreased risk of diarrheal illness. There's also a decrease in otitis media infections. So the ear is really right there by the jaw where the baby's working to suck, whether that's formula or breast milk, and so it's easy to have backflow. So having antibodies present in the milk, if there is backflow from the mouth into the ear, that's helpful and protective for otitis media. Long-term allergy as well as diabetes risks are also lower with breastfeeding. If you put breast milk on the counter for 8 hours, there's no appreciable growth, which is pretty telling and makes it a pretty amazing substance for being safe for babies. Formula certainly isn't poison, and absolutely fed is best. And formula is doing its best to imitate the components that are found in breast milk in terms of ratios of fat and sugars. But at the end of the day, if we're just comparing breast milk with formula, breast milk is going to win specifically because of those immunologic components and the impact on decreasing risk for infections. Again, that doesn't mean that breastfeeding is going to be the best choice for every family. There's a lot of factors to consider. But if we're only looking at what's in breast milk and what's in formula, it's important for us to be able to advocate for the benefits that breast milk brings to babies and their mothers, all the while acknowledging that it's a lot of work to nurse, and it's a lot of sacrifice in time and sometimes money too, and considering potential equipment needed if they need to pump, and still needing a whole bottle setup potentially if they're working. So certainly a lot of factors to consider, a lot of social and cultural implications as well. So it's certainly a longer conversation than just what do each contain, but being able to advocate for breast milk wherever possible is a good role for the midwife. Okay, breast versus bottle feeding. So what are those differences just in terms of the mechanics of pulling milk out and swallowing milk? What does that look like for the newborn? So for breastfeeding, babies are going to have their mouths wide open, whereas bottle feeding, they're not open quite as much. In breastfeeding, the lips are flanged outward, whereas with bottle feeding, the lips would be pursed in order to keep the teat in their mouth. With breastfeeding, the entire mouth is going to be filled with breast, whereas in bottle feeding, it's really only the teat that's on the tongue of the baby. In breastfeeding, the newborn's tongue will do a wave-like peristalsis-like motion for nursing, whereas with bottle feeding, it's more of a piston-like movement of the tongue, so their mouths are just functioning differently. It requires less energy for a baby to breastfeed, and it's also considered more optimal for palate and dental development. In breastfeeding, it's extremely rare to overfeed. The concentration of milk is highly regulated to meet baby's needs, whereas with bottle feeding, it's a lot easier to overfeed. That can be based on how parents have mixed up the formula. It can also be because feeds tend to be faster related to gravity and the teat's design for them to draw milk out a lot faster, whereas that's not really a concern for breastfeeding. All that to say, breastfeeding is ideal, and bottle feeding is also really common, whether that's with mom's expressed milk or whether that's with formula. But just educating on some of those differences can help parents make informed decisions on what might be best for their family with all factors considered. So now let's talk about nutrition for the nursing mother. We can recommend that they eat around an extra 500 calories a day. Certainly, baby's caloric needs are going to vary widely. A newborn is going to eat less than an 8-month-old, less than a 1-year-old. And once they start introducing foods between 4 and 6 months, that's slowly going to contribute to their overall caloric intake, especially over that first year from like the 6-month mark to the 1-year mark. And I should clarify, you wait till 6 months to eat, but sometimes at 4 months you'll start introducing just allergens enough to help sensitize. And by that I mean like the most common allergens, if you can sensitize them early, then they're less likely to develop them. For example, a little bit of peanut butter, a little bit of shellfish, that sort of thing, where they're not really bringing it in for calories, they're just bringing it in for allergy sensitization. But waiting for 6 months to actually start to have it contribute to their caloric intake each day. Okay, so back to maternal nutrition then. We want a diet that's high in protein. That's a good component of breast milk. Iron's especially good because they're going to be recovering from the birth where they likely lost a reasonable amount of blood. So we want to replenish those stores and also acknowledge that it may be a bit lower because towards the end of pregnancy, baby's going to absorb extra iron to help give them a good start, leaving mom potentially a little bit more depleted. And also a good calcium-rich diet is helpful. A perfect diet is certainly not necessary. They can continue to take a prenatal vitamin the way they did when they were pregnant. So as long as they're still nursing, they can just continue to take that prenatal. I like encouraging my moms to stay on fish oil too, both as being a consistently good fat source for breast milk, as well as helping to decrease rates of postpartum depression. So it's also great for mood support. And then initially, until they've talked with their provider, they should go ahead and avoid foods known in mom and dad's family to be allergenic. And then if they are going to explore something like an elimination diet or some kind of altered nutrition plan related to maybe symptoms they're seeing in their baby or mom, I think it's helpful to talk to a lactation consultant or some other kind of professional to help just kind of oversee and guide that process for them. That could be because they're suspecting a food allergy, or maybe they're trying to curb baby's gassiness. Whatever the case may be, I think it's nice to have a healthcare professional help walk them through that journey if they're going to significantly alter their nutrition. We definitely want to encourage them to drink plenty of water in order to quench thirst. A big water bottle just accompanying wherever their breastfeeding chair is in the house is a good recommendation. They're losing a lot of fluid through breast milk. And then there's a number of foods and substances that can be harmful for baby, where I think it's helpful to talk to parents about how our breasts are less about storage devices and more they're making milk as babies are nursing. So to some extent, they do store up some of that milk, but the majority of a feed is being made on the spot. And so because of that, if moms are going to consume something that maybe wouldn't be ideal for baby, the best time to do it would be right after a feed. What's currently in their bloodstream while they're nursing is the bulk of what baby's going to get. So substances to potentially watch out for. Caffeine can potentially make babies fussy and colicky. So if they know they're going to have a morning cup of coffee, nurse, and then have that cup of coffee. And then 2 hours later, there's not as much caffeine in their bloodstream, and baby's going to get less of it. Alcohol and drugs can also pass through the mother's milk and be harmful for baby. Personally, as a provider with alcohol, I'm more concerned about her ability to care for her baby. So if it's a glass of wine in the evening, it's unlikely to really cause any issues. But if it's enough where she might have trouble holding her baby, or if she's planning on bed sharing or co-sleeping with her baby, making sure that she doesn't have substances on board that might make her less alert and able to attend to baby's needs carefully. And with medications, there are plenty that would be fine for mom to take, but it's worth looking at each one individually and assessing whether or not it's necessary and what potential impact it could have on the baby. And again, those first couple weeks where those junctions are wide open are where it's less ideal to take something unless we're needing it. And then lastly, for smoking, nicotine does slow down the milk flow and lessen milk supply. However, breastfeeding is still better for baby even if mom smokes. It's still giving baby that immunologic edge that's helpful and protective. So then what should you consider if you're thinking you need to prescribe a medication? So is the drug necessary? Is this the safest drug to choose from the general class of medications that she's needing? Is there a risk to the infant? Can she adjust the time of administration and continue to breastfeed? You certainly always have the option of pumping and dumping, but I don't like to start there. If we can avoid that, I want to push for not disrupting our breastfeeding rhythm. LactMed is your resource for this. I think it's good to have things memorized. First line medication I'm going to give if she's got mastitis, I'm going to do dicloxacillin. For some of the more common things that you might encounter, UTI, mastitis, postpartum, you'll probably have those memorized for okay, this is my go-to safe medication or safest medication that I'm going to do for my postpartum moms. But on the whole, I'm not a fan of memorizing everything, right? So just use your resources. LactMed is great. If you just Google LactMed, it's going to take you to this website. And then there's a search bar, and you'll just type in the medication you're thinking of. Lorazepam, Prozac, maybe it's an antibiotic. Put it in, and then you click on the medication that you want to read about, and it'll give you a summary okay, this is where we're at. It's got a really short half-life. It's out of their system fast. It doesn't seem to go into breast milk. And then you say, okay, great, that sounds good. I feel comfortable prescribing it. Or it'll be something gray, or it'll be this really isn't a great choice. And then, so it'll give you a summary, and then it'll also provide details on different studies that have been done with it, and it's pretty comprehensive. So we don't have a ton of studies, but for any given medication, it's going to list out what studies have been done and what their findings were. So it's a really helpful, succinct resource for you, giving you both a brief summary as well as giving you details. So definitely use that as a resource, LactMed. There are multiple kinetic factors to consider for whether or not a drug is able to cross into breast milk. First is lipid solubility. Breast milk has a high fat content, so if a substance is fairly lipid soluble, it'll be easier for it to cross into breast milk. Molecular size. The bigger it is, probably the harder it is to be able to cross over, whereas a medication with a small molecular size would more easily cross into breast milk. Maternal blood level. So did she have that drink an hour ago, or did she have it yesterday? Or did she have it as she was breastfeeding? That would be the easiest for it to be able to cross. Protein binding also has an impact. So if a medication is more likely to be protein bound, then it would be more challenging for it to leave the protein it's bound to in maternal blood to be able to cross into breast milk. Ion trapping can play a role, particularly related to pH. Oral bioavailability in infants and mothers also plays a role. This slide starts to touch on pharmacokinetics, which you'll build on more next semester in your pharmacology course. And then I already alluded to the lactational amenorrhea method, but just to briefly revisit it here. So suckling is what's triggering the prolactin release, and that acts on the hypothalamus to block GnRH release. And it's GnRH that would then go on to trigger the release of FSH and LH. So high levels of prolactin with nursing mean low levels of FSH and LH, so we're not making and releasing an egg. And if we're not making an egg, then we don't have those follicles that are growing, that are releasing estrogen. And if we're not ovulating, then, well, one, we're not getting pregnant, if that's the part of the reason we're doing this. And two, if we're not ovulating, then we're not releasing all that progesterone. So in pregnancy, we had estrogen and progesterone blocking the effects of prolactin, but now in breastfeeding, we've got prolactin essentially preventing estrogen and progesterone from being synthesized. It's 98% effective in the reduction of pregnancy. It's especially suitable in low-resource settings and is compatible with all major religions. So within the context of it being the first 6 months, mom having not gotten her period yet, and baby not going more than 5 hours without breastfeeding, and also no formula, no donor milk, everything's coming from mom. Mom's either pumping or nursing at least every 5 hours. This is really effective birth control. Involution and weaning. Thanks for hanging in with me here. So this can really happen at any time when it's desired by mom or baby. And ideally, it's going to be a slow process. And when it ends, it wouldn't need to be final. So as far as a slow process goes, you might hear parents say, we're basically down to just nursing at bedtime, or, maybe there's just a special time of day where they choose to continue nursing. Or it could be that they've gone ahead and stopped, and then a few months later they moved, and that was kind of a stressful time, and reintroducing it for a little season just felt right in terms of providing a little bit of extra emotional comfort and support for baby in that transition. The recommendation is to exclusively breastfeed for the first 6 months, and then to continue breastfeeding alongside foods for the first year plus. And there's really no cap on that. The global average is age 4. So physiologically, the two main factors there are milk stasis and then the lack of suckling. So milk stasis, as that alveoli fills up with milk, it's going to push on those lactocytes, and that's going to release the prolactin inhibiting hormone to decrease prolactin production. And then no suckling also means, suckling is part of the trigger to go to the hypothalamus, to then go to the pituitary gland to release prolactin and oxytocin. So to not have suckling means you have less prolactin and less oxytocin as well. The time varies for every breastfeeding dyad of the chest-feeding parent and the baby. And again, you can certainly restart for illness or to help with coping as needed. And this is really about supporting both of them. So sometimes it's the baby or the child who's just very ready to be done, and a mom emotionally doesn't feel ready to be done. And it can also be the opposite, where a mom is just really needing to feel like she's got her body back and needs to have a little bit more of a boundary. So either one of them might be the reason it's initiated, and it can be hard on both ends potentially to do that transition. And so I think, a lot of emotional support and just acknowledgement for it being emotionally a tricky transition for some can be helpful for us as providers to just be able to give that reassurance and acknowledgement of that transition. Women will retain that mammary tissue that's developed during pregnancy and breastfeeding. So whenever it needs to be reinitiated, it's not going to be hard to, whether that's for this child or whether that's for a future pregnancy or adoption. And of note, while the average is a little over 4 years globally, in the U.S., the average is 3 months. And certainly there's a lot of factors that go into that at the individual level, interpersonal level, community level, social, political level, that impact a woman's ability to nurse as long as her and her baby are wanting to. So we've got a ways to go in the U.S. And then just in conclusion, I want to say that breastfeeding is really physical. As we've talked a lot about in this lecture, it's also really personal. There's a lot of values and personal choices and impact that play into it. And it's emotional and it's psychological as well. And postpartum, we just have so many hormones on board. And rather than trying to make it sound like that's something separate or different than who we are at our core, I think so much of the time our hormones are what make us up and how we feel that day, and they do run deep. And so being able to embrace that and accept and support those changes and that emotional roller coaster that can come with navigating nursing, it's definitely at the heart of what it means to be a midwife and to come alongside people in their breastfeeding journeys.